Hello and welcome to the first in the PDA Society's new series of webinars run in partnership with leading professionals in the field. Today we're delighted to have Dr. Judy Eaton with us, who's going to talk about PDA and mental health issues. Following Judy's presentation, which will last for about half an hour, she'll be available for a question and answer session along with two of the PDA Society's trustees for a further 3/4 of an hour. Please do ask any questions at any time during the webinar by typing in the box under your screen, and we'll go through as many as possible at the end. Just a few practical points before we introduce Judy. If you have any difficulties with viewing the webinar, please try making sure that you have a really good broadband connection, so 4G or strong Wi-Fi, and if you're using home Wi-Fi, make sure no other devices are connected at the same time. If you're having difficulties, you could try using a different web browser, such as Internet Explorer instead of Chrome, or clicking the View Alternative Stream button under your main window. And please remember that a recording of the webinar will also be available to watch on demand within 24 hours. I'd now like to introduce Dr. Judy Eaton. Judy is a consultant clinical psychologist. She spent 9 years as part of an NHS autism assessment and diagnostic team in the West Midlands, before spending 4 years as the lead psychologist at a Tier 4 CAMHS inpatient unit. She then set up her independent practice, Help for Psychology, in 2015. So her work has involved assessment, diagnosis and intervention with a large number of children and adults with autism in a variety of settings. Working in adolescent inpatient services led to her developing a particular interest in girls with autism and PDA. She currently leads a team which is regularly commissioned to assess very complex children and has developed expertise in unpicking difficulties associated with attachment and developmental trauma, as well as those associated with autism and PDA. Judy speaks regularly at training events and conferences about autism, mental health, and PDA. Over to you, Judy.
Hello and good morning. The topic of today's webinar is looking at the kind of mental health issues that can happen when a young person or an adult has PDA. And the aim of today really is to provide a better understanding of the kind of mental health issues that can happen. And I'm hoping that the slide has changed to the aims. To provide a better understanding of mental health issues in individuals, both children and adults with PDA, and to discuss how parents and family members can provide support. Finally, I'll have a quick look at the process of voluntary admission to inpatient services and what we call sectioning under the Mental Health Act. The aim of this webinar really is not to frighten parents of younger children. It's just to make people aware of the kind of mental health difficulties that may happen in young people and to sort of think about how to manage those. The main message is that early intervention really is vital. It's the earlier that you can get help and support for yourself and for the children, the less likely it is that they will have some of the more serious mental health issues as I'm about to talk about. And having an understanding of the kind of reasonable adjustments that can be made in order to help these young people is really helpful. I mean, some of the mental health difficulties that are associated with individuals with autism, obviously the top one, and this is PDA as well, is anxiety. And anxiety is behind a lot of the issues that can happen later on in life. Obviously, anxiety at times can tip over into an actual depression or depressive episode. Also, one of the other kind of comorbid, we call conditions that can happen with people with autism and PDA are things like obsessive-compulsive disorder, OCD. An awful lot of individuals with autism engage in repetitive activities as a means of comfort, as a way of helping them to relax and to unwind. However, when this kind of behaviour tips over into a concern about what might happen if you don't do these things, then it becomes more of a worry and can take over more of an individual's life. Obviously, things like Tourette's syndrome often appear in adolescents particularly, and that can make it quite difficult for young people to interact with others, to enjoy socialising because they're concerned about the things that they might say.
Judy, just very quickly to interrupt,
yeah.
we're just having a few comments that people are finding you a little bit difficult to hear. So if possible, could you just perhaps speak a little bit more loudly? That would be really helpful.
Okay, yeah, I'll try and do that.
That sounds perfect.
Is that better now? Are the slides moving on, Vicky?
I'm moving them on for you, so you just keep going and I'll move them on.
Okay, brilliant.
All right, thanks.
Obviously, getting towards some of the more serious kind of mental health issues, things like dissociative disorders. Dissociative disorders are not necessarily just a part of autism and PDA, but they can result when an individual gets to the point of complete overload and complete panic. If you think back to the kind of the fight, flight or freeze kind of response, you know, if you are cornered and you are unable to cope, you may fight and hit out, you may flight, you may run away, but obviously you may also freeze and actually switch yourself off from feelings that become overwhelming. And obviously this is something that is often seen in young people with PDA and autism when they simply can't cope anymore. And it can be quite unnerving and it can be quite sort of upsetting. Brief psychotic episodes as well. There is often people report that when they're in that state of complete high arousal, they experience voices, they hear people saying things to them. Often these are unfortunately are negative things. If they are in a really bad state, they may report seeing things in the room that are not there. These are incredibly scary, but they are often brief psychotic episodes that resolve when the person is not quite so anxious and not quite so upset. Eating disorders are also particularly common in sort of young adolescent females on the spectrum because it's a very convenient and easy way to control their environment. You know, if you are out of control with other areas of your life, for some people, controlling their eating and what they eat is a very good way of maintaining control. I don't really know why dyslexia ended up on that slide, to be honest. Dyslexia is not a mental illness. I think why I put it there was to indicate that sometimes associated learning challenges like dyslexia and dysgraphia, which is difficulties with handwriting, can lead to increased anxiety, which can lead to further kind of mental health difficulties. So I think that's why I included that one there. Okay, so what are the risks then for children particularly developing the kind of problems that I've been talking about? Obviously, the poor social skills and poor social communication difficulty leads to those challenges in making friends, keeping friends, saying the right thing. Lack of social imagination and inflexible thinking makes it really difficult and actually quite painful at times for young people to appreciate that someone else might have a different point of view to you or might see things differently. And often this lack of social skills and lack of social imagination can lead to rejection and bullying by peers. And there's quite a lot of evidence out there that this is a real risk factor for young people because it's been shown that they don't pick up on the non-verbals as well. I mean, particularly with girls, a lot of the kind of communication is non-verbal. There's a lot of eye rolling, a lot of looking at each other with a particular look. And often if that's missed, that can lead to poor social timing and rejection and bullying. Young people can be very vulnerable to peer pressure. Young girls and boys are particularly at risk of things like getting involved in sending inappropriate pictures of themselves or inappropriate text to people because they're simply not reading the signals right. Poor academic achievement can be a problem, like I was saying about the dyslexia or dysgraphia. Academic problems like that can lead to higher levels of anxiety. And also, if the young person is someone who tends to fight rather than flight or freeze, those kind of aggressive outbursts can lead to stress and difficulties within the family. So in terms of the kind of potential risks for adults, obviously they're similar to those experienced by children. Obviously things like poor socio-sexual knowledge, poor knowledge of maintaining and initiating and even finishing relationships is part of it. The poor social communication and the lack of social imagination, exactly the same. It's about negotiating your way around a neurotypical world. Sometimes there can be a lack of opportunity to develop intimate relationships. Sometimes there can be intimate relationships that go wrong or can't be maintained. Again, the vulnerability to peer pressure is still there. And particularly for adults, sometimes the use of alcohol or drugs as a social facilitator to try and actually feel more confident and feel more in control can sometimes lead to further problems down the line. And also with adults, sometimes difficulties holding down a job can also lead to mental health stresses and mental health problems. Okay, so thinking about anxiety and depression specifically, published studies, they reckon about 70% of individuals with autism will suffer from some form of anxiety. And in my clinical experience, that's probably an underestimate. I think the majority of both children and adults we see will suffer from anxiety and high levels of anxiety. Teenagers with autism at high risk are developing features of depression. And as I said, disorders such as Tourette's and OCD also start to emerge more as adolescents, which makes them feel alienated and different, and friendship and school difficulties. Now, these difficulties can just present as fairly low-level issues, such as negative thinking, having a low self-esteem, social isolation and withdrawal. And these are manageable up to a point. It's when it tips over into more than just spending a few hours in your room or the whole weekend in your room. It's when you actually don't want to come out of your room at all, or you withdraw from social interaction completely. That's when it becomes more of an issue. And it's quite difficult sometimes to judge at that point when it tips over from being something that the young person has chosen as time away from other people to kind of recharge their social batteries into an actual depression. And obviously parents need to look out for things like lack of interest in things that the young people would previously have been interested in, poorer, reduced appetite, generally looking low and tearful. And obviously if they begin self-harming or discussing or talking about wishing to die or wishing to commit suicide, that's when it becomes a little bit more concerning. It's easy to see how this can happen, particularly in the teenage years, and also for some young adults when they move away from home and are trying to develop an independent life. Okay. As I said, some individuals, sometimes their anxiety levels become so high that they have these brief psychotic episodes, and some of them actually shut down completely, and it's almost impossible to reach and communicate with them. Okay. In terms of the eating disorders, an awful lot of young people with autism, and to some extent the young people with PDA, may have what's called ARFID, Avoidant and Restricted Food Intake Disorder, which means that they will have a very small range of food that they are able to tolerate and a very limited diet anyway. And particularly teenage girls, this can sometimes develop into cutting down the food groups that they're prepared to even tolerate more and more and more. And I've spoken to a number of adult women with PDA who actually have reported that eating and control of their eating has become their way of managing their demand avoidance. Because as they've got older, they've become more aware that it's not acceptable to have a public meltdown. So when they feel that need for control, they turn it on themselves, they internalise it, and they manage their eating quite strictly as a way of maintaining control. Again, this becomes a problem if it gets to the point where an actual diagnosable eating disorder develops, and that then needs sort of actual professional input to help manage that particular difficulty. In terms of some of the other diagnoses that people with PDA are often given, and I've been asked this question quite a lot about personality disorder. A personality disorder is not a mental illness as such. Personality is actually a description of people's behaviour. So it's in the diagnostic manuals under the kind of heading of mental disorders, but actually what it is, it's a description of how people behave. And people can develop these kind of behaviours, which can include intense reactions to things, it can include self-harm, it can include emotional meltdowns, and it can include a history of poor and unstable relationships. But people can develop those kind of behaviours for all sorts of reasons. And very often when particularly adult psychiatry teams see this kind of behaviour, if the young person hasn't been diagnosed with autism or PDA, those kind of behaviours can be attributed to a personality disorder rather than seeing the underlying autism. Hopefully that makes sense. It is possible to have a diagnosis of autism and a personality disorder, because a personality disorder is only a description of the behaviours that are seen. However, what needs to be made very clear is the fact that there is an underlying diagnosis of autism or PDA, because the strategies for dealing with those behaviours and understanding why they are happening are very, very different. Because other young women may develop a personality disorder because of trauma or a very difficult upbringing, which is very, very different from the kind of experiences that most young women with PDA will have. Young people, if they are given a diagnosis of an emerging personality disorder, again, this often leads teens to overlook the fact that there may be an underlying undiagnosed autism or PDA going on. So it's one of those areas where people often question why they've been given this diagnosis. And I would say that in some cases it's about adult teens particularly not necessarily recognising or noticing the features of autism that might be underlying these difficulties. The other kind of personality disorder that people very often get a diagnosis of, in children, they're often given a diagnosis of oppositional defiance disorder or conduct disorder. And again, these are only descriptions of children's behaviour, and they can arise for a number of reasons. They are very different to PDA. There are overlaps, but there are also differences. There are differences in the way that these young people react to the different strategies that are suggested. Unfortunately, again, what happens if you're talking about adult teens is that young adults may be given a diagnosis of antisocial personality disorder. And again, that can be sometimes given when the underlying autism isn't noticed. And again, it's about educating and helping teens to understand that the behaviours may be the same, but the reasons behind them are completely different, and the strategies that you would use. And it's so important to recognise the underlying anxiety and the need for control that's driving these behaviours. Okay, so people have also asked whether mental health issues are just part of the autism. The answer to this is kind of yes and no. It does appear that young people with PDA do appear to have a lower threshold for anxiety, and anyone who has read any of the very helpful blogs written by adults with PDA will realise that this is part of the PDA, and it's almost as if the threshold for triggering that horrible fight, flight or freeze response is much lower. And the way I always try and explain it to other professionals and people who haven't experienced this is that it's like the very worst feeling you can possibly imagine, being there for an awful lot of the time. And again, with young people with PDA, identifying and acknowledging that that feeling is there from a very, very early age. And if strategies can be put in place to help reduce the anxiety, to reduce the level of day-to-day anxiety, and that may be a case of helping them to understand their feelings, to use scaling tools to help them to explain, to open up those lines of communication to help them learn to link those thoughts, those feelings and bodily sensations, and to be able to manage those so they don't become overwhelming and lead to this awful fight, flight or freeze response. Many parents ask how can they access services and support to help them to manage this as parents. And the reality is that many mental health teams across the country are stretched to breaking point. Mental health issues amongst young people generally are at their highest levels ever. And often, unfortunately, formal support can often only be accessed when families reach crisis point, which by that point a lot of the behaviours are so deeply entrenched, it's really difficult to work with. So as I say, if parents, want to access some of the books that are on the reading list, things like Think Good, Feel Good or Cool Connections, are very helpful, very easily available resources that parents can work through with their children when they're in the right mood and they're not in this high state of anxiety, to help them to learn how to manage and how to express their feelings and how to understand how it feels to be happy, sad, angry, what the difference between angry and sad is. And what is really, really interesting, many of the young people we see, their parents report that they are constantly eating, that they are always looking for food. And our theory around this is that actually that is the feeling of anxiety, that feeling in their tummies when they feel sick, anxious, and they often mistake that for hunger because they don't link that feeling in their tummy to a feeling of anxiety. So sometimes parents helping them to understand what it feels like to be anxious, what it feels like to be angry in your body is a good first step for helping them to manage this. And in terms of parents' own anxiety, it can be absolutely terrifying when your son or daughter says that they wish they were dead or they try and hurt themselves or other people. And seeing a child or a young person have a psychotic episode is also terrifying. In these cases, the advice would be not to panic. Obviously, make sure knives, sharp objects and things are well out of reach, because these threats are often cries for help. But unfortunately, what can happen is a lot of these young people can be quite impulsive, and they often lack the social imagination to look ahead and think what might happen. Sometimes impulsive acts can lead to unforeseen consequences. So it's a case of being vigilant and making sure the things that they could use to hurt themselves are kept well out of reach. Also, when they're calm again, don't be afraid to discuss self-harm. Don't be afraid to discuss how they were feeling. Use visual aids or scaling tools to help them explain how bad it was. Try and keep calm, because that will help to lower their anxiety. Clean wounds up, validate how they were feeling, and try not to allow your own fears about what might happen as a parent to having no boundaries for the children at all, because that actually makes things worse, because no boundaries is scary and it's not containing and it doesn't help them to manage their feelings. Moving on to mental health in adults, there's very limited research as to how a PDA affects adults. Some people seem to develop strategies for managing their anxiety, and for some of them having control over their own life and being able to make their own decisions is helpful. Some still continue to experience periods of time when their mental health suffers, And it can be very hard to access appropriate support and often benefits and things like that, because I think what people need to understand is that it can be a bit of a roller coaster. There will be times when things are going okay, but there are often going to be times when the wheels come off and that individual will need additional support and help to manage their mental health difficulties. In terms of what we call sort of serious mental health issues, and I'm aware that I'm running out of time here, briefly wanted to discuss the sectioning under the Mental Health Act. Now, individuals, adults and children can be sectioned under the Mental Health Act, and the criteria for this is if they are deemed to be a risk to themselves or other people. And the police can detain an individual. If an individual is having a public meltdown in a public place, they can actually be detained under Section 136 of the Mental Health Act, and they are then taken to a place of safety. In an ideal world, this would be an assessment suite at a hospital. In reality, this is often a police cell, which for someone with PDA who may have sensory issues is a complete nightmare, but that is often the only place that's available. People can then be held for up to 72 hours under the Section 136. If after 72 hours, and what happens is two doctors come in who are both approved Section 12 doctors, and an approved mental health practitioner who is often a social worker will come in within those 72 hours and make an assessment of that person. And if they're still deemed in need of support, they can be put under Section 2 of the Mental Health Act, which then means that they can be assessed for a period of 28 days. And this is often not a bad thing. If it's done in the right way with a team that understands the person, sometimes it can just give that breathing space to allow a team of people to find out exactly what's going on for that person and to establish some of the underlying difficulties. And sadly, for some people, that's the time when they get their diagnosis, when they finally get into an environment where there are a team of people who recognise what's going on for them. Obviously, at the end of that assessment and treatment period, if the person needs further treatment, they can then be detained under Section 3 of the Mental Health Act, which is then reviewed every 6 months. And following that, they have to be offered a period of aftercare in order to make sure that the progress that's been made isn't automatically lost. And I think that's just about the end of my whistle-stop tour of mental health issues. And I'll hand back over to Vicky for any questions or queries people may have.
Thank you very much, Judy. That was really interesting and informative.
Bit fast, I'm afraid. Sorry about that.
And once you spoke up more, we could hear you very well, so thank you very much for that.
Sorry about that.
So we hope everyone has found that useful. Please note that there are lots of links to resources in the box on the right-hand side of your screen with links to books and some of the other tools that Judy has mentioned during her presentation. And there's lots more information available on both the PDA Society website and Judy's website as well. We're now going to move on to the question and answer session, and we're also joined by Paula and Jane, who are both trustees of the PDA Society and parents to children and young adults with PDA. So if I can just check that they're on the line with us now. Hello, Paula.
Hello.
Hello, Jane.
Hi, Becky.
Excellent. That's great. Thank you very much. So we'll handle this. I will ask the questions, and Judy and Paula and Jane will respond and join in accordingly. So we've got quite a few questions that do relate to mental health and quite a few that don't, but the most commonly asked question seems to be around diagnosis. So if we can just pick that one up first. So several people asking variations on a theme of the fact that their local authority don't recognise, don't diagnose PDA. Somebody in the States who is wondering how to approach a psychologist to say that you believe your child has PDA, but most clinicians haven't heard of it. How do you go about getting an accurate diagnosis? So questions all around diagnosis, especially how you might access a diagnosis when your local area is saying that you don't recognise it. So if I could hand that one to Judy to start with, please.
Yeah, I mean, this unfortunately is a bit of a common theme. I mean, the reason for often saying that they don't recognise it is because at the moment it doesn't appear in any of the diagnostic manuals that many teams use to sort of formulate their diagnoses. So it's not in the DSM-5 and it's not currently in the ICD-10, or I don't think the revision that's coming up shortly either, which is unfortunate. It's kind of important to remember that actually autism itself wasn't in the DSM until DSM-3 in 1980. So just because it isn't in the manual doesn't mean it doesn't exist. But it takes some time before these things catch up. And I think with the research that's going on and the data that is being collected around what PDA looks like, what we need as soon as possible is a criteria, something that people can take with them and say, this is exactly what it looks like, and this is how it relates to an autism condition. This is how it's different. And I don't know whether that's helpful. I mean, the only thing you can do is take along your information, your the EDAQ that people use. I think it's something that is growing in terms of awareness across the country.
Paula, Jane, have you got anything that you could add to that on diagnosis?
Yeah, it's very, very difficult in some areas for clinicians to recognise PDA, but sometimes they may recognise that children with this cluster of symptoms do exist. And they may recognise that these children perhaps need different strategies, but don't feel comfortable to state in a diagnostic report PDA because of the research being quite slim at the moment and it not being in diagnostic manuals and so on. So what we can sometimes get in these instances is a diagnosis of ASD, but with a clear description of the child's areas of strength and areas of difficulties on a diagnostic report. And perhaps signposting to the types of strategies that may help that child. So it may just require a little bit of flexibility of thought sometimes on behalf of clinicians to try and think of how to really fine-tune that diagnostic report to meet this child's needs, even if we can't specifically say PDA. And I think this was something that was proven evident in the professional survey that we did, that quite a few clinicians were happy to say ASD and to provide that very tailored information within a report that should still support a child in the correct way, and that sometimes terminology such as ASD but with demand avoidance and so on can still signpost in the correct direction. And on NICE pathways, I think it says there in each of the ages that you look at for features of autism, there is demand avoidance. So that can be used, within the recommendations of NICE pathways, that demand avoidance is a feature, and it's just highlighting that demand avoidance is down to anxiety, over-perceived demands, intolerance of uncertainty, and so on, and how we can provide accurate, beneficial management and support for that feature of that person's autism.
Yeah, I would agree with that, but in our experience, the families that really struggle are those where the children mask and present very differently in school. Because there are a lot of teens, unfortunately, that if they don't get a consistent report from school about the difficulties being present across different settings, they sometimes struggle to even get a diagnosis, and then often, or not in a diagnosis, an assessment in the first place, and they're quite often kind of channeled off into sort of looking at attachment difficulties and parenting techniques, and they don't actually even get as far as an autism assessment. And that's what I think the biggest message we can get out there is that children can mask, they can present differently in different settings, and they can hold it together at school and for that period of time appear not to have any difficulties. And that, I think, if there's one message that we can get across to other professionals and other teams, is that isn't a reason for denying someone an assessment for autism.
Yeah, that's a really good point, Judy, because, it's difficult enough to get to the assessment stage in any way. But when a child's masking as well, and I've experienced this myself with one of my children, when a child's masking, it can make it doubly difficult. Yeah. And I think all we can suggest then is for parents to try and take information along about the concept of masking. And I know that you've written some blogs on that, which are really, really helpful. And I think there's some videos available by Phil and Ruth that briefly talk about masking, so that clinicians are aware that this can happen. And what I sometimes try and advise parents to do is to take along some written information from somebody that's not involved in the immediate family, perhaps an extended family member, a friend, perhaps somebody that runs an out-of-school activity, just somebody else that's perhaps seen that behaviour in conjunction with the parents, to at least trying to provide some evidence that this behaviour is existing, it is being seen by other people, in conjunction with information on masking as to why it's not evident perhaps at school. But it is very, very difficult. And I think a lot of it comes down to the relationship that you can form with that clinician. And the collaboration, you know, be willing to listen to each other.
I just wanted to also point out to everyone that's listening today that there are some excellent resources on pathways to diagnosis. Jane, am I correct in thinking it's under the PDA guidance, or is it on the PDA?
Yes, yeah.
Right, under PDA guidance. So maybe we could put that link up somewhere, if that's okay, Vicky, so that parents of children that they suspect may have PDA can look at the full breadth of how to achieve achieve getting an assessment for a child. The other thing I wanted to say as well is, obviously we are getting a lot of inquiries on our inquiry line now from adults who suspect they have PDA. Judy, I wonder if you could just very quickly outline the way in which an adult would go about trying to achieve an assessment.
Well, in theory, following I think the Autism Act came out in 2010, if I'm right, and the NICE guidelines for assessment of adults actually state that every area should have a dedicated team which deals with assessment and diagnosis of adults. This is the case in some areas. In other areas, it's not. In other areas, there may be a big waiting time. It can be difficult at times because some teams will still insist upon having information from early on in the young person's history, and that isn't always straightforward. If you're talking about someone who's older, who may have lost contact with parents or not have their parents anymore, that's really difficult. But what they should be doing under the NICE guidelines is looking at current functioning, looking at the kind of problems that person has experienced, whether it be in relationships, holding down a job, mental health issues, and actually pull that together. It isn't actually necessary to have a parent or caregiver give a developmental history.
Oh, that's really good information, actually, Judy, because that's a question that I've had a few times. Thank you.
It would actually be impossible. You know, it's unfair and unrealistic to deprive people for whom that diagnosis might be helpful and might help them to progress with their life, or to access particular support or benefits, just because they haven't got a parent or caregiver that can give a history. And actually, you know, if you read the NICE guidelines, it says that having a parent is great if there's one around. Otherwise, you go on current functioning.
Great. Thank you very much for explaining that.
That's great. Thank you. So hopefully that covers diagnosis as best we can in the time available. And Jane, sorry, did you want to add something?
Sorry, if we just add before we move on, that on what might be helpful to put up for parents as well is on the PDA guidance page, there is a post on there explaining the concept of masking. And also what I've done on that page is it links through to various official sources. So it links through to Judy's articles that she's written about masking, and also to the short clips from Phil Christie and so on. So it just gives something, I suppose, for people to read through, which may help them explain this concept to clinicians and provide some evidence from official sources, from other professionals to back it up.
Okay, that's great. Thanks, Jane. I'll make sure both of those are added to the resources section after the webinar. A couple of questions that relate to the Mental Health Act. So we have a parent of a 19-year-old who has been detained under the Mental Health Act, is still at home currently because mum doesn't want him to go into the local mental health unit. He was diagnosed at 16 and has at the moment completely shut down and stays in his room. Mum strongly believes that he has a PDA profile, but partly related to that he's refusing to engage with any professionals, and that's why the team seems to have decided to admit him. But Mum's very concerned that it needs to be the right place with the right professionals who understand, and wonders whether we have any advice. Slightly related to that, but a younger child who's 9 has been offered a Tier 4 inpatient during weekdays, and the parent is inquiring as to what implications would this have for him to be sectioned. So if we could try and handle both of those in one, starting with you, Judy, if that's okay.
Okay. I mean, I would be interested to know whether this young person is being offered a sort of child and adolescent. I mean, there are a number of kind of transitional units now for young people between kind of 18 and 25, because adult inpatient services are not necessarily the right place for a 19-year-old. You know, depending on how mature he is and how socially, functioning he is. The thing I would say is that I'm working with a number of young men in particular who have gone down this route of completely isolating themselves, and it's almost like their world has narrowed to the point where they stay in their bedrooms and they refuse to engage with anyone. And all I would say, it's extremely hard to get out of that pattern once it's established. I'm working with one young man who hasn't been out of his room apart from to use the bathroom for about 15 months now. And we are becoming concerned, well, his parents and I are becoming concerned that actually this might be developing into more of like a catatonia, like a complete dissociation, complete shutdown, because this young man isn't even speaking now. So I think the mental health side of it needs to be monitored. And all I would say to this mum is make sure that the team gets autism and they get PDA, and they are using the right kind of strategies and offering them the right kind of support. I know that's difficult to find out, until you actually get there, but that would be my advice for an older person. Yes, it can be useful because it can help to unpick some of the problems, but the team need to be on board with PDA and understand how it presents. I hope that makes sense. In terms of if a young person's been offered a Tier 4 inpatient service during the week, that sounds like it's a voluntary admission, which is not the same as sectioning. You can go into hospital voluntarily as a patient, which means that you can leave at any time, or you can pull away from it if it's not working for you. But you're not sectioned under the Mental Health Act. When you're sectioned under the Mental Health Act, your rights as an individual, you don't have the right just to leave. It has to be agreed by the responsible clinician who's there for your care. So in terms of a voluntary admission, that sounds like a fantastic idea if they can help to sort out any of the issues that are going on. But it's not the same as being sectioned.
Thanks, Judy. Paula or Jane, do you have anything to add to that?
Sorry, go on, Paula.
I was just going to say to Judy regarding the older child, the 19-year-old. If Mum was to find out that this particular local area mental health unit didn't have any expertise or knowledge of PDA and only very limited of autism, would she have the right to ask for an alternative?
Probably not, because it's down to availability. And all I would say to that mum is, if she finds herself in that situation, please get in touch with me and I will happily talk to the team. Because sometimes it's about strategies, it's about care plans, it's about making sure that experience is as positive as possible for that young person. If it needs to happen, then by all means, say, get in touch with me and I will happily talk to the team.
Do you think there's an alternative, Judy, to, rather than the young man going into a mental health unit, do you think there's an alternative that could possibly bring out some good outcomes?
Yes.
And if so, what would that be?
The alternative would be a community-based team of professionals who actually work with him in his own home.
Right.
Which could include a psychologist, psychiatry, OT maybe to deal with any sensory issues, maybe a speech and language therapist to help with communication. But it's that multidisciplinary approach that's important, and it would need a team that were very flexible, because it may be that he is only able to see them at certain times. That might be early evening. It's about that flexibility. That's hard to get, but actually, in terms of being the most appropriate, then dealing with someone in their own home has got to be better than taking them into a hospital setting, which is strange and different and a different kind of routine, and where the control that they do have is effectively taken away from them to a large extent.
I think that's why I actually...
Yeah.
I think it's why I mentioned it, because, for someone to come in and take that young man who's 19 into a mental health unit is going to cause him a hell of a lot of anxiety. So I think I'd heard before that there were these community teams that could come in, but yes, it would depend on availability, etc., etc. Yeah.
But that is by far the most effective way to work with family, to work with the young person, with a multidisciplinary community team, if it was available.
Okay, thank you.
Yeah, you've sort of just covered there, Paul, of something that I was going to ask you, especially for the 9-year-old. Is it better to try and get assessments done by other means rather than them being taken away for a week, to an inpatient assessment unit or so on, because of the anxieties that may cause? And do you think that might be an option as well, Judy, for the 9-year-old, if it's possible to assess them within the home?
Absolutely. I may have misunderstood that, because I thought that he was going to go as a day patient and spend some of the time during the day and then come back home at night, which is an option.
Right, it may be me misunderstanding that section.
I don't know that that's totally clear. The question says, my son has been offered a Tier 4 inpatient during weekdays.
Okay.
What implications would this have for him to be sectioned?
Yeah, because it's just, I know from personal experience that it's very difficult sometimes with our children, teenagers, young adults, that they can be so desperately poorly. But because of the demand avoidance, we can't actually get them to access the professional support. And I was just thinking, if they're sort of pushed into the professional support, whether that may have a whole new level of difficulties laid on top as well. Is there anything that parents may be able to do to help the children at home, the young adults at home, just to lower anxiety, so it may be possible for that door to support to become slightly ajar?
Yeah, I mean, obviously, reduce the demands, reduce the anxiety, talk to them when they're not in a high state of arousal. I mean, obviously, they're going to feel more comfortable in their home territory, in their home environment. However, if their home and their room is their refuge, you don't want to be kind of intruding on their refuge and their personal. It's a really tricky one. But the thing is, with kind of inpatient admission for me, if it was my child and they were really engaging in risky behaviour and were actually and needed 24 hours a day support and monitoring, I think I would rather that they were somewhere where I knew they were going to be safe. But that's what I was trying to say in the webinar. That's a tiny percentage. That's when it tips over into this is potentially life-threatening. It's only a tiny percentage of children that get to that stage. But I think in that circumstance, being in an environment where somebody watches them all day can help to take the pressure off parents sometimes if they're not getting any sleep and they're really struggling and are anxious themselves about it. But for more lower level stuff, I would totally say if it could be a community-based thing where people come into the home and help the family and the child to manage their anxieties, that would be far better. Does that make sense?
Absolutely, yeah.
Yeah, it definitely does. And I mean, obviously, as you know, I've had some personal experience of this shutdown, not going to the extremes of watching a 24/7.
Yeah.
What I found helpful, these parents may have already done this, I don't know, but what I found helpful was, as Judy says, not to intrude into that safe space.
Yeah.
But I may just go in and make a funny joke about something, or say, oh, I've just seen this on Facebook, it's really funny, I'll send it over to you, and then leave the room, so that I was trying to keep that tiny little connection, but never for it to be a demand, for it to be something unrelated to what was going on, or unrelated to PDA, or not trying to get it to open up, which I learned the hard way. I did it wrong first, which pushed them more into a room. So it was trying to keep that line of communication open, and to re-establish it, and then to build up very, very slowly on that, so that we could access support.
Yeah.
So it took perhaps about 12 months in total, from when the breakdown started, going into the room, the deep depression, then gradually trying to re-establish that connection and the confidence to build that up without the child thinking it's going to then lead on to demands and things that they find really anxiety-provoking, and very slowly introduce that professional support. That's what we found worked, but I appreciate, it's going to be different for everybody.
Yeah, and it has to be flexible, because for a young person with PDA, the demand of knowing that you've got somebody coming round at X o'clock every week, and to be ready and in a place to engage at that time is really difficult. It has to be flexible. It has to be within the child's control to some extent.
Yeah, and something that might work. And I know that Judy can offer Skype appointments sometimes. There's Skype appointments where the child can access the appointment or not. And if the child or the young adult doesn't, the parent can talk to the clinician.
Yeah.
And the child may feel free to engage, or maybe listening in the background. So they're also almost picking up helpful tips through a third person, rather than it being directed.
Absolutely. And it's not a direct demand on them to talk about their own feelings then.
And I suppose that could be adapted to somebody coming in the home. Because the person's coming, you don't need to speak to them. I'll have a quick chat, interject if you want, or, and it's just trying to think of lots of different ways to try and encourage that engagement, which can be a bit of trial and error along the way.
Yeah.
Great, thank you. I'm conscious we've got lots and lots of questions coming through, so I want to try and get through as many as we can, or try and group them as best we can. A question here about medication. So is there any particular medication that would help a child with PDA with their anxiety? We've had quite a few more general questions about self-esteem and how you can improve a PDA child's self-esteem, a young child who's had 2 breakdowns, and how can her self-esteem be protected. So I'm kind of linking that one in with this question in relation to medication. So again, if we can start with you, Judy, please.
Okay. I mean, there are different types of medication for anxiety, and there is no doubt that some can be extremely beneficial in lowering that base, or improving that baseline level where the anxiety kicks in, so it takes the edge off it. I mean, these fall into different categories. I mean, there are what we call SSRIs, which are the drugs like fluoxetine, Prozac, citalopram, sertraline, which obviously have to be prescribed by a psychiatrist. And they are the anti-anxiety medications that are used to kind of break that cycle of negative thoughts and break the cycle of kind of those rumination and when thoughts go round and round in people's heads, which is often the reason why they can't sleep at night and things like that. So they can be really helpful. Again, it's trial and error to find one that suits you or your child. There may be several different ones that need to be tried before you find the one that actually works for you or your child. The other option, which I have been working with Dr. Jo Jones, who is a paediatrician in the Midlands, she's a great fan of something called propranolol, which is a beta blocker, which is different to the SSRI type drugs. It works on the physical symptoms of anxiety, so it stops that sick feeling, that racing heart, those kind of panicky feelings. And if it works for children, it works very well, and it's not addictive, and you only need to take it as and when you need it. So propranolol is something that is worth mentioning to your GP or your paediatrician to see whether they're prepared to use it. It's been used for childhood migraine for years, so it's got a good evidence base for being safe with children. I think you can't use it if you've got asthma, but again, I'm not a medic, so forgive me if I got that wrong. But it's certainly worth mentioning that because it can be really helpful. In terms of the self-esteem question, it is about little steps, about providing opportunities for success, for building on the things that are going well and that young person is good at. And again, looking at the kind of explaining to them the difficulties that they do have. And we always use an analogy of, we neurotypicals are Windows and people with PDA are Apple Macs. They both do the same kind of thing, but they go about it a different way, and they have different strengths and weaknesses. And it's about different, not worse. And it's about celebrating their achievements and their strengths and building on those. Does that help?
Great. Thank you for that. Anything to add, Paula and Jane? And then we need to move on quite quickly, if we can, to the next questions.
I suppose it depends.
That really well from my point of view. Anyway, I'm sorry, Paul. I don't know if you've got anything to add.
No, all I was going to add is yes, that was very well covered by Judy. It depends exactly, I suppose, how much anxiety the child or the adult is suffering, as to whether it's about tackling more self-esteem and confidence, or whether you've gone beyond that and the anxiety is causing more difficulties, and therefore, we need to step in maybe with medication. And maybe only a parent and a clinician will be able to know that together.
I agree with that, yeah.
And linked to the question of medication, we've got a couple of parents of perhaps slightly older children or later teenage children who have discovered self-medication through smoking, drugs and alcohol, and some questions around the impact of that and the prevalence of that in any adults with PDA that you may have been involved with, Judy, but also perhaps the longer-term impact of going down the self-medication route.
It is very common. I mean, it's quite common in young people generally. However, it doesn't always have very helpful outcomes in young people with PDA and autism because of the way their brains are wired up. They can, particularly cannabis, and cannabis has been around a long time. At the moment, from what I'm led to believe, that the strains of cannabis that are out there are incredibly strong, much more than they used to be years ago. And it doesn't seem to mix well with the autistic brain. And it can lead to the young person becoming quite paranoid. So they can begin to become more paranoid, think people are picking on them more, that are following them, and it can actually lead to brief periods of psychosis. So if they can be encouraged not to self-medicate. I mean, I can see why, because it makes them feel chilled out, it makes them feel relaxed. However, in the long term, if they can find something other than that, it's better. As I briefly covered in the talk, self-medicating with alcohol makes you feel, if you have a few drinks, it sort of irons out some of the concerns about social difficulties. But actually, again, with that, it does open up the potential for being vulnerable, for being exploited by others, and for actually getting into trouble. And for, so again, it's something that needs a lot of psychoeducation about other ways of making yourself feel confident and happy. It's not a terribly good combination for people with autism.
I think I've experienced quite a few young people, over 18 that have contacted us, and they've got quite a problem with it because with alcohol or something like cannabis, because they've not known the dangers. And I think maybe that's something that we can't rely on schools to teach our children anymore. A lot of children with PDA aren't in school, and so that falls upon the parent, to discuss those issues with a teenager who can understand why they would be the wrong things to turn to.
And also, if they haven't got the same friendship groups or the same opportunities to talk these things over with their peers, they're not going to pick it up in the same way that other young people do, which is why it does fall on the parents actually to provide that kind of psychoeducation for them.
Yeah. And then I suppose it's finding ways to provide that education without it then being avoided. Something that can help sometimes, I don't know, is if sort of leaflets are left right lying around the house. If you can sort of say to your child, your teenager, that you're working on something to help another parent, and if they got any ideas on the dangers of these things that could help you, to provide information, so it gets them talking about it without them feeling that it's directed at them, but they'll absorb that information.
And also sometimes the actual experience of having drunk too much and feeling absolutely horrible the next day is sometimes the only way. It's a natural consequence. And actually, because they lack social imagination, you telling them that they're going to feel terrible the next day probably won't register. Actually doing it and feeling horrible the next day, natural consequence, they're learning from experience. Sometimes that's the only way to kind of get the message across, unfortunately.
And the thing is, Judy, which I think must be very difficult for parents, is if you've got a 13, 14-year-old that's beyond the stage of you've been able to keep them in the house and so on, and they're going out and doing these things, telling them not to do it is going to cause them to do it even more possibly.
Absolutely, yeah.
Is it best in this instance, perhaps, that while you're trying to educate them in stealth mode and under the radar, that you're also working at those underlying issues that are causing them to feel the need to do that in the first place?
Well, some of it will be peer pressure. Some of it will be that desire to fit in with everyone else and to be the same and not to be singled out as being different or weird in any way.
Yeah.
And that isn't just that. To be honest, that's not just an issue for young people with PDA. It's an issue for teenagers. And sometimes it is about unpicking what's the PDA and what's typical teenage exploration and responding to peer pressure, which a lot of them do.
Yeah. It's a tricky one, isn't it?
It is.
No magic answers, unfortunately. It's sort of trying to weigh up lots of different options and finding a route through them and so on.
Vicky, if I could just say, I don't know how much time we've got left, but I really would like to sort of mention eating disorders if we can, if there's any questions regarding eating disorders.
Okay, I think we did have a question in relation to eating disorders in terms of the feeling in the tummy that Judy mentioned. So if you want to just start talking about that, then I'll try and find that question again and then jump in with it when I find it. So
Judy,
a particular point.
Judy, I suppose this is my question to you, really. I've had a few parents of young adults who have eating disorders. Now, one in particular definitely had already got a particular diagnosis of the kind that you mentioned, the avoidant and restrictive food intake disorder. One hadn't got a particular type of diagnosis, just, eating disorder. And I think what they were looking for from ourselves was, well, do we just stick with the mental health teams? Do we try and find some kind of eating disorder clinic and service? Because in one case, it looked like they were leaving the young person to get worse and worse until they were literally going to take her in to some kind of treatment centre.
I mean, I would strongly recommend anybody who's got this kind of difficulty to look up a lady called Dr. Elizabeth Shea. That's S-H-E-A. I can't remember if I put that on the list of useful things. But she is a lady who works at the Birmingham Children's Hospital, I think, and she has specialised in this avoidant and restricted food intake disorder in young people with autism. And a lot of the strategies that she suggests about how to encourage young people with autism to eat and what kind of things she says you should focus on may be very helpful for any parents who've got a person who started off with this kind of restricted diet and then began restricting more and more and more. Because obviously a lot of the standard treatments for an eating disorder would be incredibly traumatic for a young person who's got autism and sensory processing difficulties.
Right.
So I would go down. I mean, she's a lady called Elizabeth Shea, and she has written about it. It's available on the internet. Her papers about encouraging young people to eat and what's the best way to do it. And a lot of it is to, again, take the demand off, take the pressure off, that kind of thing. But obviously not to leave it to the point where they're dangerously underweight and they're going to need inpatient care.
Okay, that's really, really good advice, and I'm glad you actually said Elizabeth Shea's name.
Yeah.
Her name actually came up in one of the conversations I've had with a parent. I think the problem some of these parents then encounter is, well, the young person has to engage with the service.
Yeah.
And I think that's where most parents then become so distraught because they know their young person, their son or daughter, just won't engage with the professional that's trying to offer them the service.
Yeah. That is tricky. I mean, and obviously as well, the problem is that once you go below a certain weight, once your body mass index drops below a certain level, there is evidence to suggest that you develop more autistic thinking anyway. So, and that can be people who haven't got autism. So the problem is that as the body weight goes down and they're eating less and less, their inflexible thinking and their demand avoidance will become greater. And that's the issue. So, it's very, very difficult then to persuade someone about the need for treatment and things like that. And again, it's one of those things that is not well understood. And obviously, the main focus of an eating disorder treatment is to keep that young person alive and to make sure they have adequate nutrition. And it does involve cooperating to a certain extent.
Right. Okay, so I sort of try to give the parents some advice about how to try and, reduce anxiety, reduce the young person's demands on the young person, give them lots of more choice and flexibility, in the hope that eventually she would be able to access the service. Was that the kind of advice you might give?
Yeah.
Or?
Yeah,
right, okay.
Because the bigger an issue is made out of it, the more it's going to become something to resist.
Yeah.
And it is easy for parents to get into a complete panic and think that, the young person's going to die, and it's horrible. But actually reducing the demands around eating, taking the pressure off, trying to find what else it is that might be causing them to use that as a means of control. Has it been bullying? Have they been teased about their weight? Has someone made an unhelpful comment about someone putting weight on? Do they think it's a way of becoming popular with the other girls? Has it become a special interest? Exercising and counting calories can become a special interest. And again, in that case, it might be a case of trying to find something more helpful as a special interest. Do you understand what I'm saying? It's about trying to look at the reasons why this might have developed in the first place. Because it isn't always necessarily about body image. It can be about all sorts of other things. It can be about anxiety and that need for control.
Yes. Yeah, I agree with you.
And I'm just thinking, when we're talking about eating disorders, I know this may not specifically be one, but on the other end of the scale, which is something that you covered a little bit on the webinar, is it seems to be very common for a lot of children to completely overeat.
Yeah.
And that can sometimes cause, I suppose, as extreme difficulties on the other end of the scale as those that undereat. Would it be fair to say, do you think, Judy, that it's perhaps looking at both things in the same way, that it's about unpicking at what's going on beneath the surface that's causing this either need to undereat or overeat? Because that's like a symptom, isn't it, of perhaps what's going on underneath?
Absolutely, yeah. And, as I said, a lot of children will mistake that feeling of anxiety as being one of hunger, because that's one of the things that's coming through loud and clear from the data we're collecting on the children we're seeing, is that a huge amount of them seem to have difficulties around their internal systems, whether it's using the toilet, whether it's knowing when they're hungry. It's a different kind of sensory difficulty than you see in more traditional forms of autism, if you like. There is something about that internal regulation, something about helping them to understand how these different sensations feel. Because it's very easy to mistake anxiety for hunger. And also, if you eat something, it probably does make you feel better for a while, because it takes your mind off whatever it was you were worrying about. But like you say, it gets into this cycle, doesn't it? And can cause problems.
Especially if it's sugary, it gives you that sort of instant high, doesn't it? But then you can rapidly...
You come down again,
come down again to the side.
But acknowledging the need for but perhaps trying to encourage more kind of slow-release carbohydrate snacks like flapjack and things like that, which have got oats in them, rather than having something sweet and sugary that will give you that blood sugar lift and then come back down again. Because, again, these kids with PDA, they're a bit like a jam sandwich. Their kind of calm alert state is quite sensitive, and they can dip down, and then they can suddenly shoot up and go into kind of hyper mode. It's almost like their internal systems are a bit finely balanced, and they tip over into kind of manic hyper behaviour quite easily. So it's about keeping that blood sugar level with slow release carbohydrates and perhaps cereal bars and things like that.
That's really interesting what you've just said, that some of these rapid swings that we can see may not just be emotional regulation, but may be a reaction to. That's really interesting.
I think there's something physiological going on with these kids. Again, it's early days, but we're collecting all the different profiles as we see more and more children. And there's something in this about internal regulation. So it's not just control of their emotional state, it's that their internal regulation, it makes it perhaps impossible to... Makes it more difficult. I don't know about impossible, I think more difficult. And I think it's again, these kids are like layers of a sponge cake. There's so many different things going on for them, and it's a case of unpicking what it is that's underneath some of these behaviours in order to kind of intervene and help them.
Very interesting. Lots of food for thought, pardon the pun, on on lots of different issues. That's really interesting.
And slightly related to this, but on a slightly different topic, somebody's son is morbidly obese, and the specialist is recommending surgery, but the son will barely visit a doctor at all, let alone have any tests done. And so this mum is sort of saying, obviously very worried for his future health, but how do you convince a probably young adult or late teen age son with PDA and a learning disability to engage in the tests that are necessary for his overall health and well-being? Judy, any tips?
That's I mean, if you're talking about learning disability, I would be more inclined to go down the kind of social stories route and that kind of thing, and use a lot of visuals. But again, it's about convincing him that it's good for him. I mean, are there any things that he can't do that he would be able to do if he wasn't carrying quite so much weight? I'm just wondering whether you could kind of look at the things that you could do. But it depends what his motivation. If his motivation is to play PlayStation all day, then that doesn't really make that much difference. I'm just wondering whether there's something that could be used as a kind of something that would benefit him. Because I think an abstract concept like health and well-being in the future is probably not going to work terribly well.
So, for instance, the parent may have to find something that's going to motivate him to want to, have a better outcome for his health in the first place.
Yes.
Right. Yeah.
But just, I think an abstract thing about it's not good for you in the long term that probably doesn't mean a great deal to him, I wouldn't think.
The other thing, Vicky, is I know that some children with PDA don't take to social stories. Some do, some don't. And sometimes we have to actually visit the surgery or clinic, wherever the young person needs to go for, say, a blood test or blood pressure. We have to visit quite a few times and actually start to engage with the nurses and doctors there before the child can even go and actually have any treatment done. And something I know that we had to investigate at one point, our paediatrician had to write a letter to our GP to say that our son needed regular appointments because he had to... he has heart problems, and he has to have, several blood tests, treatments, scans, etc. And he was starting to build up, refusal to these things. And so we had to actually say, he needs to visit more often to become comfortable with that place and to gain trust in the doctors and nurses to enable him to have the treatment. So sometimes it's about visiting and coming away just having said hello and seeing the surgery.
Yeah, it's a great idea, Paula, and something else that we've been trying that may work for other children. It depends how acute the anxiety is, doesn't it? Something that we're finding helpful is if we've got something coming up, because we've got the internet now, which can be fabulous, is actually pulling up information on that place on the internet, looking at pictures of it, looking at YouTube videos of how things are likely to pan out. So for a certain type of treatment, we would look at YouTube videos of other people having it. And we found that my daughter can sort of process that and pay attention to it and sort of go through it easier because she's not directly involved in it, she's observing it. And that can help to reduce anxiety for her over then taking part in it. So that's another option as well that might be helpful for some individuals.
Great. We're coming towards the end of the time, but just to pick up a question relating to an adult and in terms of the sort of support that may be available when you're high functioning in some ways but very disabled in others. So just to read you the details, my daughter is coming up to her 26th birthday and was only diagnosed 2.5 years ago with ASD, PDA and ADHD. A month later, we also found out she urgently needed a pacemaker. We're struggling to find help and support. Again, when she's high functioning, it's hard for people to believe her. She seems to be only entitled to 10 hours support a week, and they're just young girls with no experience at all. And so any tips on how to access the right sort of support when, on the one hand, you are seen as high functioning, but on the other hand, are too disabled to be able to work and function normally? Shall I point that at you to begin with, Paula?
You can.
Thank you.
Right. I was just trying to think of a suitable reply. I think, okay, the young person has actually been awarded the support. So she's got 10 hours a week support. It might not be enough, but, we've got 10 hours. If they want more, they have to go back and have a reassessment of her needs, possibly with more evidence from different practitioners of what her needs are. Then about the support workers, it is difficult to get the right support. There are two ways. You can either rely on your own local authorities' support workers, or you can advertise and recruit your own support workers. You would need a direct payments or a personal budget to actually advertise and recruit your own support workers. Whichever one you go for, they will need training. And I think that's the key here. It certainly has been with our own young adults that live with us, that it is in the training where you then tend to get staff that want to stick around. They understand your young person, and they have the right knowledge to be able to support them. So that's what I'd say. It's about getting some ASD, PDA, ADHD training for those support workers.
And I think that training, Paula, as well, because there are so many services now that are offering training, even if it's training, that's geared towards parents or for people within education and so on, it can all be adapted, can't it? And it's quite inexpensive, really, to attend half-day or one-day workshops.
Yeah, because, if it's the local council support workers that are coming in, then they can train a vast amount of staff on one day with one workshop. Not just those working with that young person.
I know of the training workshop that we ran yesterday, there was about 5 or 6 professionals there that had come in order to learn to support children that they were working with. And also, I'm just wondering if the parents are aware of perhaps accessing some financial help via PIP. And there's also the other thing, isn't there, for parents, for individuals that can't go to work, if perhaps if you could access some of those benefits, if that could then be used to employ people.
Yeah, in particular we're talking about PIP or employment support allowance.
And there is links to that on our website as well. I think it's under resources for families now. We've got links to those.
Those benefits.
To access that,
Brilliant. Thank you very much. Judy, did you have anything to add on that before we wrap up?
No, not particularly. I think that I've spoken to a number of adults who have found it quite difficult to put together the case for PIP because of the fluctuating nature of their needs. And I think that is what needs to be sort of stressed in this, that sometimes things can be okay and they can appear to be functioning okay. At other times they'll hit a period where they're unable to do anything for themselves, even perhaps wash, dress, make their own meals and things like that. And I think that's the hard part for people who don't get PDA to understand how that works.
I think at the moment, Judy, there's only sort of, is it welfare rights and places like that you can go to?
There's advice bureau as well, I think,
right.
you can go to who can be quite helpful.
Right.
But yeah, it is a case of somehow managing to get across that, because they often talk about what a good day looks like. And it's often hard for people to predict when a good day is going to happen and how often that's going to happen. And even on a good day, they may still be limited by certain things. I think the criteria that people who do the assessments use needs a bit of a rethink. There's almost a training issue there as well, actually.
I think I echo that, definitely.
I think it may be helpful for adults, if possible, if they've got somebody, perhaps a parent, a friend, a family member, that can really help them complete that form.
Yeah.
And there is guidelines on the National Autistic Society of how best to fill these forms out. And, for example, for disability living allowance is the one that I'm used to filling out. And supporting parents with, and it is to write down your experiences on your worst days, rather than on your best days, and that's what I was advised to do. But that may be easier to achieve if there's a parent or a family friend that's assisting them in writing that form. So it's really getting across the difficulties.
Brilliant. Thank you very much for all your answers. Thank you to everybody who asked questions. I think that's all we're going to have time for today. We will reply to all the remaining questions via email, and if anyone has any further questions, please do get in touch with our PDA Society inquiry line team, and we can be accessed on info@pdasociety.org.uk. Thank you very, very much for Judy's time on the webinar and on the question and answer session as well. We very much appreciate that. And we look forward to welcoming everyone again for our next webinar in the series, which is PDA and how speech and language therapy can help, which will be on August the 29th, and the details of those will be announced shortly. Thanks very much.